Hello, my name is Wayne Brisbane. I am an assistant professor of urology at UCLA, and I'm going to be talking about microultrasound and MRI for visualization of prostate cancer. So a couple of disclosures. The most important, I think, is that this is a sponsored talk by Exact Imaging, who makes microultrasound. So let's talk about what are our tools for visualization of prostate cancer. Well, there's really two big ones. MRI has been a powerhouse for the last decade. Microultrasound's a newcomer. When you look at the accuracy between these two, I'm using this recent comparative study by Klotz. They're very similar in sensitivity and specificity. I know a lot of us will argue about these sensitivities and specificities. They vary widely through the literature. However, no one will argue that the cost of MRI is a considerable concern. This is the cost for the United States, runs around $3,500, maybe down to $2,000. But in general, microultrasound is going to be about a tenth of that. Additionally, for MRI, there is usually a diagnostic encounter followed by a biopsy encounter if there's a concerning lesion. So the patients are coming back multiple times. It's hard for the patients, increases carbon footprint, just overall cost. So the nice thing about microultrasound is you can do your diagnostics and you can do your biopsy in the same setting. Now, I'm not ignoring PSMA. I think it's fantastic technology and probably is going to revolutionize prostate cancer care, but no one would argue that we're decreasing cost with PSMA. It's definitely going to be an expensive modality for many, many years. And then the sensitivity and specificity, while fantastic, are usually performed in a non-diagnostic setting. So this is going to be a screening setting in those men who are enriched for prostate cancer. So it will change these numbers. Additionally, you're introducing radiation, so it may not be appropriate as a screening study. So for the purpose of this talk, we're going to talk about MRI and microultrasound. So for those of you who are a little less familiar with microultrasound, these are comparative images in the axial plane. So this is conventional ultrasound. It's at about 9 megahertz. This is microultrasound, about 29 megahertz. You can see on conventional ultrasound, there's ability to differentiate between the transition zone and the peripheral zone. But in general, this peripheral zone looks fairly isoechoic all the way throughout. When you look here on the microultrasound, again, you can easily differentiate between those two zones. But here, there's kind of this hypoechoic smudgy pattern that I'm drawing out there. This is what we would consider a primus 4. It's this mottled appearance, and it's increase in echogenicity compared to the background stroma. And that indeed was a 4+3 prostate cancer in this man who had a robotic prostatectomy. So what are we getting with this increased frequency? Obviously, the pictures look different, but what are the physics behind it? Well, with this increased frequency, this 29 megahertz is a measurement of the how close these wave patterns, these acoustic wave patterns are together. And as you increase the megahertz, this distance between these goes down. And so as that distance goes down, it improves your resolving power, which is your ability to differentiate between two objects and visualize them as separate objects. So for microultrasound, that goes down to 70 microns or 0.07 millimeters. For regular ultrasound, that's about 200 microns. And so when you look at these Gleason patterns, which I've cartoonized over here, it's the importance between being able to tell these things as a gland that's open or a gland that's closed. And that makes a difference. So I took a micrograph here. This is the box where we're zoomed in. And this is the gland right here that we're measuring. I know this number is small, but it's about 516. And this is a small gland. You can see a little bigger one right over here. So this is a gland that's right adjacent to this cancerous tissue that's starting right here, about 516 microns, versus this gland right here, which is a cancerous gland, is 90 microns. So as you're improving your resolution power, the idea is behind this is that you're actually visualizing the change from these benign patulous glands to a cellularly dense cancer. And this has been codified in the Primus score. So walk you through this. This is, again, I just put these Gleason kind of cartoons at the bottom, but you can see here that you have these wide open patulous glands. This is in the setting pretty much very, very protective. There's very rarely cancer in this because this is normal, non-condensing prostate tissue. It's doing its job. As you start to move into more dense tissue, you can still see these glands or these ducts in cross section. So you're seeing them, but they're starting to kind of condense. They still have a hyperechoic background, which is protective. So this would be considered Primus 2. 1 and 2, again, mirrored on PIRADS. This is going to be something that's not as aggressive. When you get to 3, though, you lose the glands to a large extent. So this figure right here, you can maybe see 1 or 2 in the background, but you have this hyperechoic background. So there's usually this stromal tissue in the background, not as cellularly dense. This would be considered a Primus 3. When you start to lose the glands and have a hypoechoic background, an enrichment in the cellularity, what you then are moving into is this kind of mottled or smudgy appearance, which is classic for PIRADS 4. And when you have a very, very cellularly dense hypoechoic background, so you basically lost all the glandular appearances and you have this internal hypoechoic streaks, that's very cellularly dense, and that's going to be a Primus 5. And so the idea again is that you're able to visualize this transformation from your benign large glands that are doing their work to these very cellularly enriched glands that are probably condensed, and then these highly aggressive cancerous glands. Now, I've been showing you all these pictures in Axial because we're all very familiar with Axial. That's what MRI and CT often comes out in its native imaging. But microultrasound is native in its sagittal plane. And the reason for that is because in order to create an axial plane with ultrasound, what you have to do is you'd have to make a curvilinear array. And a curvilinear array decreases your pixel density as you go farther and farther away from your imaging plane. So this is something I think is an appropriate decision that the engineers at Exact Imaging said, well, in order to improve the crystal density for imaging and get our good resolution, we're going to do this in a sagittal array. And then in order to get different images, we will rotate. And so everything will be native sagittal, but then we will reconstruct in the axial plane. If you wanted to know what native axial will look like, this is what it looks like in our lab. But we basically took a prostate out, put it in a box, and then translated a microultrasound along it with a mechanical arm. So this is native axial, but in the imaging setting for patients, you're going to have native sagittal. And this is what it looks like. So compared to native sagittal in the MRI, you can see this area, which is hypointense. Here on microultrasound, hypoechoic. But you can see this is, a fairly good representation of those two areas. I've got this big gland up here. I've got these little 3 glands right here, and then the bladder neck right there. So you can see by comparing these two images, actually in the T2, there's less spatial resolution. A microultrasound, that's all you get. So we have to have good spatial resolution and really good tissue resolution. But in MRI, obviously, you get a ton more imaging sequence with your ADC, DWI, and contrast enhancement. So here you're looking at multiple different series and lining them up for your diagnosis. Here, you're looking at imaging patterns and trying to see how are these imaging acoustic features indicative of benign tissue or cancer. Now, when we actually compare how people doing this, in general, I won't go through all of these, but the end result is that they're rather equivalent for diagnostics, grade group 2 prostate cancer and above. Multiple different study designs, including meta-analyses. Others have mentioned optimum. I'll discuss it in a bit, but what I want you to take away is, in general, across multiple prior study designs, there's been an equal diagnosis of prostate cancer on microultrasound and MRI when you use this grade group 2 and above threshold. So this is my particular setup while I was at the University of Florida. It's for transperineal biopsy, just stirrups, microultrasound, and then freehand biopsies. I'm going to show you the collation of my results, but I think it's nice to actually see a case example so you can see how the data was recorded. So this is a 56-year-old male, PSA 4.2, normal digital rectal exam, PIRADS 4 at the left base on MRI. So I'm going to switch over to a DICOM viewer. So to start, we're on the right side. This is in a research environment, but usually what you get is as you rotate, you get an angle output. This is the angle output right here. It's in millimeters just because it's my research environment and the engineers it was an easy DICOM hack. But regardless, you can see a very nice picture right here of this that's a Primus 1 output, these nice patchless ducts going in through there. You can see a couple other structures. I'll draw your attention to this very nice transition between the peripherals and the transition zone. So you can see this anterior apical horn very nicely. As it comes up, it's like this Nike swoosh of tissue. The peripheral zone kind of comes up into the anterior apex. And so a very nice visualization of that. As you come more to the midline, you can see this very big cyst there. There's a nice demonstration of a large BPH nodule that is very benign. So you can see the bladder neck here, this urethra going through. You can see the ejaculatory duct coming into the vira montanum. And as we go further and further over, you can see this hypoechoic kind of concerning area right here. Irregular borders, pretty much loss of the ductal architecture, and you start to see the development of these hypoechoic streaks versus right here where you're seeing large ductal areas right there. And then you kind of see this, area in between. We're going to chat about that. All right, so the other nice thing is that you can visualize once you've taken a biopsy, because obviously these biopsy cores are 18 gauge, so you get to see where these biopsies are. And oftentimes there'll be scar tissue there, so you can actually go back to the same location and repeat biopsies for men on active surveillance. This is taking all of my data in aggregate, so 101 men. All these guys had an MRI microultrasound, and then at the time we got a digital rectal exam. Our overall diagnosis for prostate cancer was 51%. And you can see visually, this is the sensitivity and specificity both for MRI and microultrasound. So you can see both have very high sensitivity, as we previously reported in Dr. Klotz's data, but the specificity is somewhat diminished. You can see on MRI, it does appear visually that it's a little better over here, but when we compared the two with statistical tests, there wasn't a difference. You obviously can improve the specificity in both modalities by adding in digital rectal exam and PSA density. But what I wanted to show you is, why is it that we have this very high sensitivity, but a more concerning specificity? And you can see right here, this very nice delineation. This is clearly one, but as we go forward in the scan, there's this area right here that has some of our features of a Primus 4, right? You've lost a lot of your ducts. It's got cellular features within a prostate that appear concerning. Again, this is hyperechoic, but has lost a lot of its patulous ductal features. And so microultrasound is when you have that Primus 1, Primus 2 features, the ductal appearances there, very rarely to be cancer, but there are other features within the prostate of cellular density, prostatitis and such, that will cause a visual appearance of cancer. So you can see here that this is a combination of MRI and microultrasound. And if you combine them, at least in my data, I found that there was some synergy in combining. So just you can see that the specificity improves by combining both microultrasound and MRI. This further was stratified by Primus and PIRADS. So you can see here, this is the PIRADS going across the top. This is Primus going down. And if you have a PIRADS 5 or a PIRADS 4, and you concomitantly have a Primus 5, you virtually always have prostate cancer. Again, this is a small series of 100 patients, but quite often do you have prostate cancer. Again, kind of interesting feature is if you have a PIRADS 5, and you have a decrease in your Primus score, you're going to decrease your rates of prostate cancer. So again, there's some synergy between MRI and microultrasound. Optimum is a study that is up and coming. This is going to be a randomized, multi-institutional, multinational trial of microultrasound versus MRI, and hopefully we'll be reading out sometime in 2025. So in conclusion, microultrasound is a real-time imaging modality for prostate cancer. Our prospective blinded comparison with MRI is pending maturation and optimum, but it's something that is available currently, and there's some very interesting data out there. I find that microultrasound and MRI provide some diagnostic synergy, and there's likely molecular and tumor phenotypes visible to each modality, and something that I think would be very interesting going forward as future research. Thank you very much.